next talk is posterior uveitis, and this distinguishing between infectious versus non-infectious. And for it, I invite Kalpana Babu Murthy from Eye Clinic, Bangalore. Kalpana, please.
Thank you, Dr. JB, for this invitation. It's not open.
Questions will keep at the end.
I do not have any conflict of interest. The slides are not moving. So to begin with, when we say we are seeing posterior uveitis, what are we actually referring to? So we are actually looking at inflammation of the retina and the choroid and maybe the adjacent vitreous. So it is important for us to find out what is causing posterior uveitis, and broadly we can divide it into infectious, non-infectious causes and masquerades. And our main aim and the interest of this talk is how do we differentiate infection from non-infection. And so I'll be concentrating on the infectious uveitis and what we should not miss. These are the different infections which can cause posterior uveitis. So most importantly is there are some pointers, and history is a very, very important clue to differentiate. And then I'll be looking at certain specific clinical phenotypes and patterns which should not be missed. And also a review of systems which can help you come to a kind of a decent conclusion whether we are dealing with infection or non-infection. And then you tailor your investigations, be it ocular investigations or systemic investigations, which will confirm your diagnosis. So let's look at the history. So when we see a patient first, it is important to know from which area this patient is coming from. So the geography plays a very important role because there are certain diseases and infections which are endemic to certain regions, and so it is important to keep that in mind. Also, immune status will give you a clue. Check whether this patient is an uncontrolled diabetic, is he a patient with HIV, patient on chemotherapy, and these are the cases where infections are quite common. Always inquire if there's a history of fever, weight loss, recent admissions, infections, IV fluids, previous stents which this patient may have had, any indwelling catheters, any history of recent travel, treks, hiking, tick bites. They will give you a kind of clue that you may be dealing with infections, while in non-infections you have more generalized systemic complaints. Examination actually reveals quite a bit, and you should look for specific clinical patterns, and sometimes involvement of adjacent structures will help, and also reviewing the systems will give you a good idea. So let's look at certain clinical phenotypes which you should recognize. The first frame is retinitis, where usually the lesion is in the retina. The margins are blurred, they are more yellow. Choroiditis is much more deeper, and they have more demarcated borders. And unlike retinitis, it's a little more darker, more orangish. This is vasculitis, where it is affecting the vessels. If you have the retinitis along with the disc involvement, we call it neuroretinitis. Sometimes you can have pockets of fluids where we call it as serous retinal detachments, and you can just sometimes have just disc edema when we call it as optic nerve involvement. So let's look at the retinitis phenotype per se. And one important pointer is when you're dealing with retinitis, it's usually an infection, except in patients with Behçet's disease. So I think here we have to differentiate. So let's look at the common infections such as toxoplasma. It is very, very clear. This is usually focal. And sometimes you can see this kind of a scar adjacent to the retinitis. You can have this retinitis very close to the disc where we call it neuroretinitis. And you can also see a lot of vitritis, and this is what we call as the headlight in the fog appearance. Usually these acquired lesions can come without a scar, so this is something which we need to keep in mind. Viral infections are another common cause of retinitis. Acute retinal necrosis follows a characteristic pattern, starts from the periphery and then comes to the center. This is the classical brush fire or the pizza pie appearance we see with CMV retinitis. This is what we see with progressive outer retinal necrosis, and measles, some kind of a vague posterior pole involvement, and this is something very classical, post-fever retinitis. Another important emerging infection is syphilis, and these are the classic presentations, the posterior precoid pattern. You can see this kind of pre-retinal nodules in front of the retina, and this is the ground glass or the opaque retinitis, which you can also see. Sometimes it can be atypical. You think that the fundus is normal, but your ancillary investigations can give you a clue, which I will be showing you shortly. And here, these lesions like on the palm and sole will also give you a clue. When you have retinitis like this, you should always have to inquire about the significant history. So if there is a history of fever, skin rashes, rickettsial is something you need to keep in mind. Recent hospital admissions, you keep in mind fungal retinitis. Now, the other retinitis, which is autoimmune, is Behçet's, and generally they come with occluded vessels. It's more of an infiltrative type of retinitis, and this is associated with other adjacent local and systemic features. OCT plays a very crucial role, and sometimes you can see this ILM bridge sign with necrosis of the retina in toxoplasma or measles infections. This is the classic raindrop sign, which you usually see with fungal retinitis. Toxoplasma is very characteristic. There is a full thickness retinitis with a thick posterior hyaloid and like what we call as the waterfall effect, because the choroid is also involved. Syphilis is very characteristic. You have an outer retinal involvement. And as I showed you in the previous case, you do see, on the autofluorescence, you can see changes. And this is the classical fern-like appearance which you see with fluorescent angiography in Behçet's. So when we see retinitis, you look at the serology to rule out these infections. You can do a HLA-B5 if you are suspecting Behçet's. Blood culture and urine culture helps in these cases, and sometimes you need to use the PCR on the ocular fluids to confirm the diagnosis. Another important phenotype which we see in our part of the world is what we call a serpiginous-like choroiditis, and it is very characteristic. You have these multifocal lesions and some are kind of confluent, and you see this kind of pigment hyperplasia, and you also see this kind of paradoxical reaction, and OCT is very characteristic. You see the splitting of the RPE from the Brooks membrane, and this is what we call as the double layer sign. And here we use the autofluorescence and OCT to monitor the activity in these patients. So generally, when we see this kind of a pattern in an area which is endemic for TB, we usually keep this associated with ocular tuberculosis. And this is an interesting paper which we had published earlier, where in an endemic country, even if your MAN2 and quantiferon tests are negative, but this clinical phenotype is very significant, the chances of this being, it's better to err more in terms of ocular tuberculosis. In contrast, in sarcoid, which is a similar disease but an immunological disease, you see this kind of an irregular depigmentation, and you can see this kind of depigmented scars in the peripheral retina, and sometimes this can also look like Dalen-Fuchs nodules. Another important clinical phenotype is granulomas, choroidal granulomas, and one of the infections which we need to keep in mind is tuberculosis. So generally, TB granulomas are more fewer. They are usually along the blood vessels, and this can be larger and associated with a lot of exudation, and sometimes you can even see this kind of wrap lesions. So here the OCT plays a very important role because you can see the full thickness choroidal granuloma, you see this contact sign, and you also see some amount of outer retinal hyperreflectivity. In contrast, sarcoid granulomas, which are usually autoimmune, are usually multiple, and they're more deeper, and they're more orangish or darker. And usually this can be partial or full thickness, and the OCT plays an important role. You see these as homogeneous, well-demarcated granulomas, which are hyporeflective with increased transmission signals. Another disease which does occur as posterior uveitis is VKH or sympathetic ophthalmia. Again, the history plays a very important role, and this is associated with generalized full thickness of the choroid, and you can see this undulations of the RPE, and here the FFA and ICG will play an important role. Sometimes sarcoid also can present like this, and so generally when you see a diffuse thickening of the choroid, you go more in terms of a non-infectious cause. Posterior scleritis is another such disease which can mimic VKH sometimes, but you can see this kind of chorioretinal folds both clinically and on the fluorescent angiogram, And of course, the B sign is very characteristic on the ultrasound examination. So when you see posterior scleritis, you need to look for a systemic disease. So you rule out rheumatoid arthritis, systemic vasculitis, and connective tissue disorders in these cases. My last phenotype is retinal vasculitis. So basically, when you see a patient with retinal vasculitis, it is important to find out what vessel is it involving. Is it an artery? Is it a vein? Because there are certain diseases which can involve only one of them or both of them. And also look at adjacent areas around the vasculitis. So in this patient, generally we want to rule out TB, and some of the markers are, you see these kind of granulomas along the vessels, you see this kind of chorioretinal scars which are pigmented, and usually TB-related vasculitis are more occlusive. A nice study from LVP has also shown that you can see this kind of tortuous vessels around these chorioretinal scars, and you can also see this kind of looping around these scars. If I can just take a minute and I'll just complete it. So earlier we used to label as Eales disease. Sometimes you can have just vitreous hemorrhage presenting, and it is important to look carefully in these patients for any lymph node enlargements elsewhere, and mainly rule out TB in recent times. In contrast, sarcoid usually does not occlusive vasculitis, and it is usually kind of what we call as a candle wax dripping. And if you can see, it's like a candle wax dripping. So this is very, very characteristically seen in sarcoid. I would just like to bring in this one case because it's very important not to miss this diagnosis. Now, this is a patient with systemic lupus, and if you can see, you have involvement of both the arteries and veins. So when the arteries are involved, it is very, very important. And these are actually not retinitis patches, but these are actually arteriolar occlusions which can be missed. So this is where a fluorescein angiogram and OCT will help you to find out. And when you see a lot of arterial occlusions with involvement of both arteries and veins, it's always important to rule out systemic lupus. So these are the investigations which I would probably do in patients with retinal vasculitis, depending on what kind of characteristic vasculitis I'm seeing. So to conclude, when I see a posterior uveitis, I would be paying a lot of importance to history, the clinical phenotype, the pattern, is it a recognizable pattern, and I would tailor my investigations accordingly. A pointer is whenever I see retinitis, always rule out infection. And whenever things are not fitting into the usual style, which is atypical, these are the ones which will pose significant challenge to you. And my caveat will be, if you don't know what you're dealing with, please avoid intravitreal steroids. And sometimes you err more in terms of treating the infection, like you assume it's an infection and treat it. And if you're still doubtful, you can just try a course of systemic steroids. And if it is worsening or there is no response, you're erring more towards infection. Thank you.